clot from migrating from the lower limb to your lung if we put upfront IVC filter. So we put the IVC filter upfront, produce the angiojet kind of thing, or use the angiojet to suck out all the thrombus from lower limb. That will prevent pulmonary embolism. And for that for that complex intervention, we have our team. We can perform that thing, and patients acute decompensation risk will be somewhat mitigated. Then we can use this OAC or NOAC or heparin or low molecular heparin according to our need, according to the bleeding, according to the patient status. But the acute condition or the risk of developing an acute condition, that acute P, will be mitigated. So we use that one. So this is the IPC filter. We first went through the right femoral vein and installed IVC filter. So we know that IVC filter will prevent any clot from migrating from lower limb to heart or lung. Then this is angiojet. We punctured from popliteal one. So in right, you are putting IVC thrombus. In left, you are entering from a popliteal one, popliteal vein, USD guided puncture, popliteal vein. Then above, you just putting your angiojet device. It will produce a whirlpool effect, suck out the whole thrombus, and then we'll keep the IVC filter there, wait for maybe a couple of months, and then remove it. These are our plan. So large bore device which sucks out all the clot by a whirlpool mechanism. This is an angiojet. So before the angiojet, this was the thrombus. And now you can see the thrombus is almost gone. So this is the layering in CT venogram, and this is a DSA of this popliteal artery. So the patient was salvaged from this acute condition. Patient was initially on heparin for just one day, and then we planned this whole mechanism, stop the heparin overnight, and then next day morning, first case, we put the patient on cath lab table. This DVT was treated mechanically. IVC filter was put on. Patient was kept on observation for 24 hours. There was hemolysis. Hemoglobin again dropped to around 6, and some AKI. Patient creatine was around 1, and then the next day creatine was around 1.6. Almost 12 hours patient was oliguric, and then again everything gone up. So angiogeted large bore devices cause little bit of hemolysis, little bit of AKI, but these are for the time being. If you tide over the crisis is around 12 hours to 24 hours, depending upon the other risk factors patient is having, whatever is hemodynamics of the patients. Mostly we see that around 12 hours or 24 hours after this event, patient usually the crisis is over and patient usually is going up. So after that we started anticoagulation, oral anticoagulation. NOAC was started, that is rivaroxaban 15 milligram twice a day for 21 days and 20 milligram thereafter OD. This was the dosing for DVT treatment. So for DVT treatment, we can use either heparin, then Clexan or Clexan, and bridge over to any kind of NOAC or warfarin. The standard dosing is 20 OD. But if you treat with NOAC only, there is no bridging. If you plan, that I will not give any kind of heparin or low molecular heparin, directly will shift over to oral ones. Then we can use apixaban or rivaroxaban. The dosing is little bit different. That is 15 milligram twice a day for 21 days and 20 milligram once a day for 3 months or 6 months, depending on the patient's situation. That is for rivaroxaban. If you use apixaban, then 7.5 milligram twice a day for 7 days and then 5 milligram once a day. twice a day to continue. This is for apixaban. These are the two dosing profile we chose rivaroxaban because we have more hefty data on rivaroxaban in DVTP treatment. So next day, this iron profile, APLA, factor 5, Leiden mutation, lupus anticoagulants, all are there. I mean, all we sent. But the thing is that as the patient is on heparin before, and then we shifted to NOAC. Definitely we had to because this is a thrombotic burden was higher. We know that I mean, thrombus is there in the right. DVTs was there in non-critical. P was there, so we had to use some form of anticoagulation. We on anticoagulation, this lupus and uh, this factor 5 Leiden mutation test or APLA tests are not that much uh, standardized. So ideally, we should stop all the anticoagulation and then wait for a couple of days and then send Aplan this thrombotic profile test. But we had no other choice, but because patient is already having thrombus, so we thought that put the patient on regular dose of anticoagulation. When everything will be settled down, maybe after say 2 weeks or 3 weeks, then we'll stop the anticoagulation, wait for a couple of days, and then send Aplan. The already on board. We yet to grab the results of these important tests. So within a couple of days, pain subsided, AKI subsided, hemolysis subsided, hemoglobin was around 8.8. After say, 2 days, he was clinically better. Rivaroxaban was started, and I mean some bits and pieces of physiotherapy and how to live a healthy life. These were all counseled, and APLA was sent. We are still hoping for a good result. So something is there. So we thought something is there. So the diagnosis is still yet to be made, but either SLE or APLA, this kind of autoimmune disorder, ulcerative colitis is a part of that disorder, or as a whole, this is an ulcerative colitis and acute thrombotic stress. Somehow, that top tipped an acute thrombotic state in ulcerative colitis. That is the at least 10 or 12 papers are there. Patient is suffering from girls suffering from ulcerative colitis. Somehow, patient developed DVT and PE. And patient was on steroid and mesalazine, and they were put on NOACs. Patient bled, and this angiojet and penumbra system were used to suck out all the thrombus, and patient lived, fine thereafter. So papers are there, at least 10 to 12 papers are there in ulcerative colitis and acute thrombotic state. But here the diagnosis, maybe by this Saturday, by this weekend, we'll make the diagnosis because all the reports will be coming by then. Thank you. Hope you enjoyed the thing.
Yes,
And if
yes, sir.
you have any question, you can shoot.
Sure, sure, sir. Thank you so much, sir, for the insightful presentation. Now, let us see what are the questions that have come from our audience. And I would request everyone who have joined, kindly put your questions in the chat box. I will be able to read them out to sir.
So where is the chat box? I can find that thing. Any question?
Sir, you won't be able to see it. I have the questions with me, sir. 1 minute, sir.
Okay. Please read
Sir,
out the
how do the hormonal factors like contraceptives or pregnancy play a role in the thrombosis in young female?
Yeah, definitely. We know that, contraceptive pills and pregnancy is a thrombotic state. They can produce a thrombotic state. Many a times we see that this APLA, we know that how APLA works in pregnancy, and usually the pregnancy area where this APLA patients are diagnosed. And OCPs are, plays a very important role. Whenever we find this kind of acute thrombotic state in females, we ask for OCPs, but there is no history of OCP intake in this girl.
Okay, sir. Sir, how do genetic and autoimmune diseases contribute to thrombosis event in young women, and when should we suspect them?
So, every autoimmune disease are having some. element of there's a possibility the patient may have some thrombotic state, be it inflammatory bowel disease, be it autoimmune hepatitis, be it your autoimmune pancreatitis. These are all associated with this disorder. In every autoimmune disease there is a chance that patient may have a DIC like symptoms, or patient may have some thrombotic like symptoms. It's a part and parcel of autoimmune, whole autoimmune disease, be it SLE or or MCD or systemic sclerosis, whatever you name it, any autoimmune disease, and you will find that some amount of thrombotic disorders or papers are citing that there is a thrombosis in these patients. And we know
Sir,
that protein S deficiency, factor V laden mutations, lupus anticoagulation, anticoagulant related issues. These are common in autoimmune disorders.
so there is one more query, that is, what is your approach to diagnosing and managing a first-time venous thromboembolism in a young female patient with no obvious risk factor?
No, if the patient presents with this thrombotic status only, then definitely the game will be much easier. You will straightforward, go for NOAC or OAC, warfarin, acetrom, or any kind of NOAC among our three or four drugs, which we are having in our basket. So, as this patient is suffering from anemia, severe anemia, and ongoing blood loss, that is the main problem. You use this anticoagulation. Definitely, we use this anticoagulation, and these are warranted in this case. But as the patient is having ongoing blood loss, that's the dilemma, whether we should use the full throttle anticoagulation. The full throttle anticoagulation definitely may reduce the DVT burden within maybe a couple of days, or maybe in a week. We have not to use that angiojet device or IVC filter. And the problem is we couldn't use this full throttle anticoagulation because there is ongoing blood loss. That's why we have to use these devices to and bail out the thing, and then you can use anticoagulation, or if the bleeding happens you can stop anticoagulation and bridge with the heparin or whatever be the thing, you can deal with the thing. That's the main agenda here.
Right, sir. Thank you so much.
Thank
So,
you.
one last query has come. So, what red flag symptoms should not be overlooked in young women presenting with non-specific signs like fatigue, pallor, or leg pain?
Pardon, just repeat the question.
Sir, what red flag symptoms should not be overlooked in young women presenting with non-specific signs like fatigue or leg pain or pallor things?
Menstruation history, OCP intake history, these two are very much important, and family history. And this cyanosis, or if your if you put the your fingers in cold water, you are having cyanosis or paleness or blueness in your skin. There is Raynaud's phenomena. These should not be overlooked. Chest, lung should not be overlooked. So these are the things where you should, or you uh, usually find features of autoimmune diseases: skin, lung, and history of OCP intake, history of pregnancy, family history. These are important.
Right, sir. Thank you, sir. Thank you so much for answering all the query. With that, I would like to conclude the session. But before concluding, I would like to thank you on behalf of the IGCP team for taking out your time and giving effort for this session, sir. Thank you so
And
much once again. Thank you all
thank,
for joining, and thank you all for your questions. Thank you, sir.
thank,
Thank you so much.
thank